Hello everyone, welcome to my channel. I am Dr. Rebecca James, Faculty of Biochemistry. If you are new here, don't forget to subscribe my channel, press on the bell icon, and if you want to get notification, don't forget to press the all button as well. In this video, I am discussing about the June 2020 Jipmer Biochemistry recall questions. So we'll go to the questions. The first question is, von Gierke's disease the most typical symptom? The first option is fasting hyperglycemia. Remember, it is not fasting hypoglycemia, it is hyperglycemia. Hyperuricemia, branched chain glycogen deficit, cardiac abnormalities. So we will be seeing one by one. So first we will consider the fasting hyperglycemia. In von Gierke's disease, what is the enzyme that is deficient? Is glucose 6-phosphatase. Okay. Now, what is the function of this enzyme, or what is the reaction catalyzed by this enzyme? This enzyme catalyzes the conversion of glucose 6-phosphate to glucose. In what all pathways this reaction comes? The number one is, you know, that the glycogen, when it is degraded, after multiple steps, it reaches the glucose 6-phosphate and it has to be converted to glucose, and that is by the enzyme glucose 6-phosphatase. Then is there any other role for glucose 6-phosphatase? Yes, you can see that. In the pathway of gluconeogenesis, I am just writing here pyruvate. You know, it's a substrate, the pyruvate, or you can know lactate, pyruvate. So many substrates are there. I don't want to describe on the gluconeogenesis here, but we should know that whatever is a substrate, it will become pyruvate and it go to the gluconeogenesis pathway, and finally that will also end up in the glucose 6-phosphate and it has to be converted to glucose, right? So this is gluconeogenesis. So if this enzyme glucose 6-phosphatase is deficient, the final step of two pathways are affected. One is glycogenolysis, the second is gluconeogenesis. What is the role of glycogenolysis? The role of glycogenolysis is in the stage of early fasting. Okay, so what's the role of gluconeogenesis? Once the glycogen stores are depleted, the body has to depend on gluconeogenesis, that is non-carbohydrate sources, so that this can synthesize glucose from non-carbohydrate sources, and that pathway is called as gluconeogenesis, newly synthesizing glucose from non-carbohydrate substrates. So once the glycogen stores are depleted, the body is depending on non-carbohydrate sources for glucose, right? But what happens here? The gluconeogenesis is also not taking place. So in von Gierke's disease, two pathways are affected, glycogenolysis as well as gluconeogenesis, which means the body's blood glucose level cannot be maintained in the early fasting state as well as in the fasting state. Because in the early fasting state, glycogenolysis will not take place. In the fasting stage, the final step of gluconeogenesis, which is glucose 6-phosphatase, is also not taking place, which means the body will be having what? The body, or inside the blood, the glucose level will come down. So that is fasting hypoglycemia. It is not hyperglycemia. So the option 1 is out of the question. It is not the correct answer. Now I am moving on to the other symptoms of this von Gierke's disease. Usually the symptoms, if I am describing, the symptoms of von Gierke's disease, usually the age of onset is 3 to 4 months. And how do they present? Or you can see there will be chubby cheeks, or we also say it as doll-like facies. Then we can see fasting. Already I have explained that. Fasting, hypoglycemia, and all the symptoms due to hypoglycemia. They will be having hepatomegaly, then there will be renomegaly, but splenomegaly is not commonly seen, it's very rarely seen. So these are some of the symptoms of von Gierke's disease. Next, what are the biochemical hallmarks? The biochemical hallmarks are: 1. Already we have described hypoglycemia. 2. Lactic acidosis. 3rd one is hyperuricemia. 4. Hyperlipidemia. Okay, so these are some of the biochemical hallmarks. So if I am considering all these things, you can see here in the option there was one option which was called as hyperuricemia. So I don't want to describe all the biochemical hallmarks in this small video, but I will be describing about the hyperuricemia. Why there is hyperuricemia here? Hyperuricemia is because the enzyme that is deficient here is glucose 6 phosphatase. Phosphatase is deficient. So as a result, you can see that there is accumulation of glucose 6 phosphate. This glucose 6 phosphate can enter into HMP pathway. So from HMP pathway we know that it is a source of pentosis in our body. So this pentosis will increases the synthesis of purine. So if there is increased purine, naturally the purine degradation products will also increase, which lead to increased uric acid. Because uric acid is the degradation product or catabolic end product of purine, right? So that is why there is hyperuricemia in von Gierke's disease. What type is the von Gierke's disease? It is a type 1 glycogen storage disorder. Is it liver glycogen storage disorder or a muscle glycogen storage disorder? It is a liver glycogen storage disorder. And so we'll move on to the next option. So we have seen hyperuricemia. It is a most typical symptom, or it's a characteristic symptom of von Gierke's disease. Now the branched chain glycogen accumulates. In von Gierke's disease, glycogen is accumulating, and that is why there is hepatomegaly. Glycogen is accumulating. Why? Because glycogen is not getting degraded, so naturally glycogen will get accumulated. But that glycogen that is accumulating is not an abnormal glycogen, it is a normal glycogen only. So glycogen is accumulating, but that is normal glycogen. It is not a branched chain glycogen, or it is not this a polysaccharide with more branches or a polysaccharide with less branches. No, it is not like that. So the cardiac abnormalities is a feature seen in type 2 glycogen storage disorder, that is a lysosomal storage disorder. Lysosomal storage disorder, and that is Pompe's disease. What is the cardiac abnormality you see in type 2 glycogen storage disorder or Pompe's disease? There is a hypertrophic cardiomyopathy. So there is hypertrophic cardiomyopathy in Pompe's disease, not in type 1 von Gierke's disease. So what is the answer here? So the answer here is hyperuricemia. B is the answer here. So moving on to the next question. A patient with history of self-mutilation with increased uric acid level. It's a very simple question. You all know it is Lesch-Nyhan syndrome. It's not uric acid, it is not gout or malignancy. Now, what is Lesch-Nyhan syndrome? We know that the Lesch-Nyhan syndrome is a disorder in the purine salvage pathway. What is the enzyme that is deficient in Lesch-Nyhan syndrome? It is hypoxanthine guanine phosphoribosyltransferase transferase. What's the function of this enzyme? This is the enzyme which convert hypoxanthine as well as guanine. We know the phosphoribosyl pyrophosphate is the donor for the ribose and the phosphate. Then this will become the pyrophosphate, and hypoxanthine, by receiving the ribose and the phosphate, it is becoming a nucleotide, and that is inosine monophosphate, and on the other side this is guanosine monophosphate. Okay, so this enzyme is deficient in the case of Lesch-Nyhan syndrome, and it is an X-linked recessive disorder. X-linked recessive disorder. Very characteristic presentation of the Lesch-Nyhan syndrome is self-mutilation. It is compulsive self-mutilation. Compulsive self-mutilation, and they have hyperuricemia. Hyperuricemia. So this uric acid, now why there is hyperuricemia in Lesch-Nyhan syndrome? The reason is, we know that the enzyme that is deficient is this part, right? So what will happen? The hypoxanthine and guanine will accumulate. So we know that hypoxanthine and guanine are purines. Okay, so if there is increased purine, naturally there is increased purine catabolic end product. What is the purine catabolic end product? It is uric acid. Okay, so there is hyperuricemia. One more reason for hyperuricemia is that as this enzyme is deficient, we know that there is excess of PRPP, which is again a activator for purine synthesis. So this will also increase the purine synthesis. Okay, so as there is increased purine synthesis, there will be increased purine degradation product as well. So there is hyperuricemia. So I am moving from this question to the next question. If proline is replaced by aspartate on 28th position of the B chain, there is 28th position of the B chain, what does it result, or what does it form? So this is about the various insulin preparation. We'll discuss about the various insulin preparation, then I'll come back to this question once again. Okay, so one option that is given was glargine insulin. We know that insulin is having two chains, the A chain with 21 amino acid and the B chain with 30 amino acid. Okay, in glargine insulin, what is the substitution or extension that is happening? Two main to prepare this pharmacological insulin analogs, what we usually do is base substitution or an extension of or addition of 2 amino acids or 3 amino acids, etc. So we will be seeing what is glargine insulin. So glargine insulin is, I will be writing it this for you because I don't know whether this is clear to you. So we know that in the A chain, the asparagine at the 21st position of the A chain, asparagine in the 21st position of the A chain is replaced by glycine. Okay, so that is a substitution. And one more thing that happens is, we know that in the B chain totally there is only 30 amino acid. So in glargine insulin, the 2 extra amino acids is added to the 30th position, so that 2 arginine and arginine 1 and 2 arginine is added to the 30th position of the B chain. So we see the name of this enzyme, the name of this insulin preparation is glargine. See, you find anything that is peculiar for that name? Glargine. So GL stands for the glycine and argine stands for the 2 arginine residues which is being added, which means whenever a new preparation is produced in this insulin, the newly formed insulin is not by the newly added amino acid. In this case it is glycine and arginine, so hence the name glargine insulin. Okay, now I am moving on to the next one, which is Lispro insulin and the glulisine insulin. First, what is Lispro insulin? So now you understand something is there in the name of the insulin analog or insulin preparation, that is Lispro. So we will be seeing what is this Lispro first. In Lispro insulin, we know in the B chain has 30 amino acid. The 29th and the 30, 28, 29, 30. The 28th amino acid is proline normally and the 29th amino acid is lysine. This is a normal B chain of insulin. Whereas in this case, this proline is replaced by lysine and this lysine is replaced by proline. So this is called Lispro insulin. That Lispro, why that name come? Because of these 2 amino acid that is being substituted, that is why it is called Lispro. Okay, Lispro insulin. Now coming to the next one, that is glulisine. So what is glulisine? Glulisine, the change is happening, base substitution or the amino acid substitution is happening in the B chain itself. And here the 3rd amino acid and the 29th amino acid is changing. The 3rd amino acid is asparagine normally and the 29th amino acid is lysine. 29th amino acid is lysine. This asparagine is replaced by lysine. Okay. Now this 29th lysine is replaced by glutamic acid. Glutamate. Okay. So that is why it is called GLULYSINE. So glutamate and lysine is coming newly. So this and the name of this insulin preparation is glulisine. Okay, so normally, usually what is the newly arrived amino acid and the newly formed insulin preparation is known by that name. So this is glulisine. Now we have come to the 4th insulin preparation, that is aspart insulin. Aspart insulin. What is aspart insulin? Aspart insulin, the amino acid substitution happens in the 28th amino acid of the same chain, that is B chain itself. The 28th amino acid is proline. This proline is replaced by aspartic acid. It's replaced by aspartic acid. So what is happening here? So the newly arrived amino acid is aspartic. So what is the name? It is aspart insulin. So even if you don't know anything, you can just guess what is the newly arrived amino acid and you can come to an answer. I'll go to that question once more. So if proline is replaced by aspartate, which itself means that aspartate is the newly arrived amino acid, so that insulin preparation is not something, that name is having evidence of that newly arrived amino acid, that is aspartate. So that itself give you a guess that this is aspartate insulin. So if that was newly arrived amino acid was lysine and proline, then that amino acid is Lispro insulin. If the newly arrived amino acid is glutamic acid and lysine, that is glulisine. If the newly arrived amino acid is glutamic acid and arginine, that is glargine. So this question, the answer is aspartate insulin. Coming to the question number 4, which enzyme reverses the step of pyruvate kinase step in the gluconeogenesis? So we know that the pyruvate kinase is an irreversible step of glycolysis. This irreversible step of glycolysis is reversed by two key enzymes in gluconeogenesis. So we will be seeing these two. The enzyme pyruvate kinase, we know phosphoenol pyruvate is converted to pyruvate. The enzyme is pyruvate kinase. This is a step in glycolysis. Now the question here is, which is the enzyme that reverses this? Which means, which is the enzyme which converts pyruvate back to phosphoenol pyruvate, and that is taking place in gluconeogenesis. Okay, this step is catalyzed by two reactions. The first reaction is the pyruvate is first converted to oxaloacetate, and this is by the enzyme pyruvate carboxylase. Okay, so pyruvate carboxylases, the peculiarities are, number 1, this reaction takes place in the mitochondria. Secondly, this is a reaction that requires ATP, biotin. So this is a biotin dependent carboxylation. The next thing is that this oxaloacetate, which is formed inside the mitochondria, this is inside the mitochondria, has to be pumped to the cytoplasm, because the next step is taking place in the cytoplasm. So that is with the help of malate shuttle, but actually the complete malate shuttle is not involved here. So this reaches the cytoplasm, and in the cytoplasm the oxaloacetate is converted back to pyruvate by the enzyme phosphoenol pyruvate carboxykinase. So which are the two enzymes required here? The pyruvate carboxylase and the phosphoenol pyruvate carboxykinase. So coming back to our question, it's a very simple question. Pyruvate carboxylase is the answer here, not PFK, not glucose 6-phosphatase or fructose 1,6-bisphosphatase. So which are the key enzymes of gluconeogenesis? The key enzymes of gluconeogenesis are The first one is the pyruvate carboxylase. Then we have learned about the phosphoenol pyruvate carboxy kinase. Then we have fructose 1,6-bisphosphatase, which is this enzyme. And lastly, we have glucose 6-phosphatase. So these are the 4 key enzymes of gluconeogenesis. But in this particular step, what we need is pyruvate carboxylase. So going to the question number 5, it is not a calcium binding protein. So calcium binding protein, calmodulin, definitely we know that the calcium calmodulin complex is formed, so definitely it is a calcium binding protein. Now going to the cal binding, that is also an enzyme protein that binds to the calcium. We know that it is important in the absorption of calcium in the intestine as well as the reabsorption of calcium in the kidneys. Then the tropomyosin. The tropomyosin is not the answer here. Sorry, it is the answer here. And we know troponin. Troponin, you know that there are 3 types of troponin, and out of that troponin C is a protein that binds to the calcium, trop C. That binds to the calcium. So calmodulin, calbindin and troponin, all these 3 binds to the calcium and not tropomyosin. So the answer here is not a calcium binding protein and it is tropomyosin. Going to the question number 6, false regarding brown fat. Brown fat acts as a reserve lipid. Thermogenic activity is facilitated by uncoupling reactions. The uncouplers present in the outer membrane of the mitochondria. Brown fat do not generate ATP. So false is the question here. We'll see the first option, brown fat act as a reserve lipid. That is not completely correct, but we'll see for the best answer here. Thermogenic activity is facilitated by uncoupling reactions. That is definitely correct. We know that the brown adipose tissue has thermogenin or uncoupling protein 1. So this thermogenin is the one which is acting as a physiological uncoupler, which uncouples oxidation from phosphorylation. So oxidation or the electron jumping will take place. What is the peculiarity of that electron jumping? That oxidation is not coupled with phosphorylation. Okay, oxidation means this electron jumping. Phosphorylation means the conversion of ADP to ATP. Usually these two are coupled together, but in the presence of this uncoupling protein, they are uncoupled. So what is happening? Phosphorylation is not taking place, but electron jumping is taking place. This electron jumping is having one more peculiarity, that is, it is an exothermic reaction. Okay, so if oxidation is happening, what is happening? Heat is being generated. So that is thermogenic activity is facilitated by uncoupling reaction. That is a true option. Then uncouplers are present in the outer membranes of the outer membrane of the mitochondria. No, this is present in the mitochondria. Inner mitochondrial membrane. So it is in the inner mitochondrial membrane. Then the brown fat do not generate ATP. Yes, that is also true option, because I have already explained this uncoupling. So there is no phosphorylation, so it will not generate ATP. So in this options you can see this is a true option. The uncouplers are present in the outer membranes of the mitochondria is a false option. Then D is also a true option. Brown act as a reserve lipid is not fully correct, but we have two options here, and I don't know whether there is a mistake in the recall as well, but I will say the best answer here is the uncouplers are present in the outer membranes of the mitochondria. That will not be the answer, because the uncoupling protein, it is present in the inner mitochondrial membrane. So the answer here is C. The best answer here is C. Okay, now the question number 7. Garrott's tetrad include. The Garrod's tetrad is a very age-old tetrad. That is, 4 inborn errors of metabolism was first studied by Sir Archibald Garrod. And these 4 disorders which he studied together and found out to be an inborn error of metabolism is called as the Garrod's tetrad. What are these 4 inborn errors of metabolism, or 4 disorders which he named as inborn errors of metabolism? Is CAP. CAP. What is this CAP? The CAP is cystinuria, albinism, alkaptonuria, and pentosuria. So these are the 4 components of the Garrod's tetrad. So Garrod's tetrad in the or from the given options, this should include alkaptonuria, not HFI, not PKU or homocystinuria. It is not homocystinuria, it is simply cystinuria. Remember, it is cystinuria, not cystinuria. Cystinuria. Question number 8, role of glucose in the treatment of acute intermittent porphyria. Options are facilitates excretion of porphobilinogen, decrease heme synthesis, decrease ALA synthesis, inhibit ferrochelatase. So there are 2 close options here, decrease heme synthesis and decrease ALA synthase. Now I'll show you what is written in Harper about this. In Harper, it is given as ingestion of large amount of carbohydrate and administration of hematin repress ALA synthase to diminish the production of heme. So 2 options are correct, decrease heme synthesis and decrease or decrease ALA synthase. 2 options are there. So in these 2 options, decrease heme synthesis or decrease ALA synthase, the correct answer here is decrease ALA synthase, because that is the best answer than decrease heme synthesis, because it is specifically written in Harper that it is repressing the action of ALA synthase. So the answer here is C. So added to that, I'll just give you one more point, that is in diabetic patient, if a porphyric patient or a patient with porphyria develop diabetes, what happens is because of this increased glucose level always in his blood, the symptoms of porphyria will usually never aggravate or never appear in a porphyria patient. So it is actually a protective effect, that is if a porphyric patient is becoming diabetic, the symptoms of porphyria will rarely manifest. Why? Because the glucose metabolite in the glucose is repressing the ALA synthase, so which is decreasing the heme synthesis, which has other effects, but still it is something which is compensating for each other. That is, in diabetic patient, the symptoms of porphyria, if that patient is porphyric patient also, the symptoms will very rarely appear. And that is why there is one more thing that you have to learn there, that is if a porphyria patient is starving, then the symptoms will suddenly appear. Why? Because this inhibition on ALA synthase is lost, which means there is accumulation of the porphyrin precursors, or the accumulation of heme synthesis, intermediates of heme synthesis will accumulation of the intermediates of heme synthesis will take place. So that is why porphyria is symptoms will appear. So especially acute intermittent porphyria, there is symptoms will appear if the patient is starving, and if we are giving, that is why in acute intermittent porphyria we will give a IV glucose. Okay. Monoclonal antibodies are produced by, we all know the answer here is Hybridoma technique. I want to describe a little bit about Hybridoma technique, which is a little difficult to understand topic, but once you understand, it's very easy topic as well. So we should know what is the concept of monoclonal antibody as well as a polyclonal antibody. So if we are giving an antigen challenge, the body produces different types of antibodies. against various antigenic determinants. So if you are giving an antigen challenge against various epitopes, then it will produce lot of antibodies. So that is called as a polyclonal antibodies. So under such situation, different clones of antibody forming cells are synthesizing the antibody. So that is why, and these molecules will have different specificities as well as affinity. That's very simple to understand. So that is called as a polyclonal antibody. So antigenic challenge, different epitopes, so a variety of antibodies are produced which is having different specificities and affinities. That is called polyclonal antibodies. Now what is a monoclonal antibody? Monoclonal antibody, if only one clone of antibody cell producing cells are secreting antibodies, which means the antigenic, we are giving a antigen or an antigenic challenge to a particular epitope. So we are giving not a antigenic challenge, it is not a generalized antigenic challenge. We are giving an antigenic challenge to a particular epitope of the epitope, and hence it only single clone of antibody producing cells will be activated, and that will be producing clone of that particular antibody, and it is not having multiple specificities or affinity. It will be a unique, or it will be unique to a particular antigen, or unique to a particular antigenic epitope, right? So that is called as the monoclonal antibody. Now we are able to produce the monoclonal antibody experimentally, and that can be used. It has variety of uses in the pharmacological aspect. So we will be seeing what is the biochemistry behind this production of this monoclonal antibody. That is what we are going to discuss, which is called as a hybridoma technique. Why it is called as a hybridoma technique? Because we are using, to produce this monoclonal antibody, we are using a fused cell or a hybrid cell. What is this fused cell? We are selecting this fused cell by growing this fused cell in a culture media. What is this culture media? The culture media is called as HAT medium. HAT medium. Now what is this HAT standing for? The H is standing for hypoxanthine. The A is standing for aminopterin, and the T is standing for thymidine. Okay, what is this importance of the HAT? Hypoxanthine, you know that the hypoxanthine by the help of salvage pathway, we know that the IMP and GMP can be, IMP can be produced. From IMP we know that the purine can be synthesized. The purine nucleotides can be synthesized. And thymidine, you know, it's a pyrimidine. It's a pyrimidine. Now what is this aminopterin? Aminopterin is a folate antagonist. Folate antagonist. So what will happen? If the folate antagonist is present here, this will inhibit purine de novo synthesis. So salvage pathway can take place, but purine de novo synthesis. Okay. Now I am moving on to how this hybrid cell is produced. So hybrid cell is grown in a medium which is having the HAT. HAT means that in that medium de novo purine synthesis will not take place, and only synthesis or the only source of purine here is the salvage pathway. Now we'll see how this, or what is this hybrid cell? What are the components of this hybrid cell? This hybrid cell is having two components. The number one is a myeloma cell. Myeloma cell. What's the peculiarity of a myeloma cell? The myeloma cell is a cancer cell. It has in the cancer cell is having telomerase activity, so there is a possibility of multiple cell division, so immense proliferative capacity is there. So here the immense cell division or immense proliferative capacity of multiple cell divisions can take place. So it is otherwise called immortal cells. So they are immortal. It won't die even if you multiply generation after generation. But myeloma cell has one deficiency. What is that? It lacks salvage pathway. And what was the peculiarity of that HAT medium? The only way to synthesize purine was salvage pathway, which is blocked in the myeloma cell. But what is the advantage of myeloma cell? It has multiple cell divisions possible. They are immortal cells with immense proliferative capacity. Now going to the splenic cell. So the second thing which is fusing with the myeloma cell is splenic cell. What is the peculiarity of the splenic cell? That splenic mouse cell is having, or we are injecting a particular antigen. That splenic cell is immunized with a specific antigen. So if that splenic cell is injected with a particular antigen, what is the peculiarity of that splenic cell? It can produce what antibody? It can produce the monoclonal antibody. So that clone of that antibody producing cells will be activated. So this will be producing monoclonal antibody. So that is the peculiarity of this immunized splenic cell. What is the second peculiarity of this immunized splenic cell? The splenic cell has salvage pathway. Splenic cell, the salvage pathway is present. Then what is the next deficiency of the splenic cell? It is not an immortal cell. Proliferation, proliferative capacity is not there. Proliferative capacity is not there. It's not an immortal. It's a it can after multiple cell division, it will not, it will die. So these two cells are fusing together, which means one cell which has an immortal nature or immense proliferation is fusing with the splenic cell, which is not immortal, but this splenic cell is having what medium? It is having a salvage pathway, so it is a source of purine is there even if we have an inhibitor of de novo purine synthesis. And what is the other peculiarity of the splenic cell? It has the peculiarity to produce the monoclonal antibody. So if these two things are fusing, we will get an immortal hybrid cell which has a immense capacity to produce a monoclonal antibody. So this is the basic principle of hybridoma technique, and the name I've told you because these two cells which is helping each other, it's actually a symbiosis. One is lacking proliferation, which is helped by the myeloma cell. One cell is lacking salvage pathway, which is helped by the splenic cell which has the salvage pathway in it. So this is called as the hybridoma technique, and this is how we produce a lot of monoclonal antibodies. I don't have to mention about the monoclonal antibodies and the lot of maps, that I don't have to tell you. Okay, so we will move on to the next question now. Going to the question number 10, insulin independent glucose absorption. We know that insulin dependent glucose absorption is by glucose transporter 4. It is insulin dependent. And which are the sites where this insulin dependent glucose absorption is present? It is heart, adipose tissue and skeletal muscle. skeletal muscle. These are the three sites where insulin dependent glucose absorption is present. So the question here is insulin independent glucose absorption. So it will not be heart, it is not adipose tissue or muscle, and the answer here is kidney. So like these kind of question, you can select the odd one out. We know that heart, adipose tissue, muscle is having glucose transporter 4. The answer here is kidney. Moving on to the question number 11, neuropsychiatric symptoms seen in which porphyria? The options here is acute intermittent porphyria, erythropoietic protoporphyria, congenital erythropoietic porphyria. Neuropsychiatric symptoms is a part of neurovisceral symptoms. So in this neurovisceral symptom, the neuro component is one which is the neuropsychiatric symptoms, and the visceral symptoms are the GIT symptoms. Okay, so we will move on to what is the basis of, or what is the concept behind the symptomatology of various porphyrias. If the enzyme deficiency if it is early in the pathway, or it can be late in the pathway. So if it is early in the pathway, two things which accumulate is there is increased ALA and PBG. If it is late in the pathway, then porphyrins accumulate. So if ALA and PBG accumulate, we can see that there is neurovisceral. That is what we write short form NV, and this neurovisceral is having the neuropsychiatric symptoms. So if there is increased porphyrins, the manifestation is photosensitivity. And in the porphyrin, we know that the porphyrin comes from the UPG, uroporphyrinogen, coproporphyrinogen, and the protoporphyrinogen, which can be converted to the corresponding porphyrins, which are uroporphyrin, then the coproporphyrin, as well as the protoporphyrin. So if the porphyrins is accumulating, it will cause photosensitivity because of its conjugated ring structure, and that is why there will be photosensitivity if the enzyme deficiency is later in the pathway. I know that this table will not be clear to you, so I will be explaining it. We will be seeing the first enzyme onwards. ALA synthase. ALA synthase deficiency will not cause any porphyria, but there is a mutation which can happen where there is a gain of function mutation. If there is a gain of function mutation, then that can cause X-linked protoporphyria. That is a different entity, but from the ALA dehydratase and uroporphyrinogen 1 synthase. So if these two are deficient, that is ALA dehydratase and uroporphyrinogen 1 synthase is deficient. This uroporphyrinogen 1 synthase deficiency is also, the same enzyme is also called as HMB synthase or PBG deaminase. All these names are there. So if any of that is not any of this enzyme, if this enzyme which is called by any of this name is deficient, it causes the most common acute porphyria, and that is acute intermittent porphyria. Acute intermittent porphyria. And in acute intermittent porphyria, ALA and PBG accumulate, there will be neuropsychiatric symptoms. Coming to the next enzyme onwards, that is uroporphyrinogen 1 synthase defect. It causes congenital erythropoietic porphyria. Then uroporphyrinogen decarboxylase, if that is deficient, it produces Porphyria cutanea tarda. Then CpG oxidase, it causes hereditary coproporphyria. If there is a deficiency of PPG oxidase, it causes variegate porphyria and ferrochelatase. If ferrochelatase is deficient, it causes protoporphyria, erythropoietic protoporphyria. This is the various porphyrias and the enzyme deficiency. So once the uroporphyrinogen 3 synthase onwards, if it is present or if it is that enzymes are lacking, it produces photosensitivity. Before that, ALA dehydratase, uroporphyrinogen 1 synthase, if it is deficient, that is acute intermittent porphyria, the classical presentation will be neurovisceral symptom. There will not be photosensitivity. Going to the last question in this session. I don't remember what are the, or I don't know what are the options here, but I'll tell you the question. HbA1c 6%, what is the glucose level? How to calculate the estimate average blood glucose level if HbA1c level is given? There is a formula for calculating that. It is the relationship between the A1c, EAG means estimated average blood glucose level, is by the formula 28.7 into the HbA1c level minus 46.7. So in this option we can see the HbA1c given is 6%. So we have to multiply 28.7 into 6 minus 46.7. If you solve this problem, you will get the answer as 125.5, and this value is in milligram per deciliter. This value is in milligram per deciliter. So this answer here is, one option was there, that is 126. You know that this is the cutoff level where we are saying a patient is diabetic or not, and so less than 6% of that is, if HbA1c is 6%, less than 6%, it is corresponding to 126 milligram per deciliter of blood glucose. Before concluding, one day or day one, you can decide. One day we know that we don't know when it is going to come. But day one is today. It is at your hand. We know that time and tide waits for no man, and time is very precious. So let today be the day one, not one day. And thank you. All the best.